and it's, the teaching is often you can't diagnose a heart attack through a left bundle branch block. You can see that with this left bundle, you have this ST elevation, accordingly, and you would be wrong if you called that a heart attack. But there are situations where you can diagnose a heart attack with left bundle. This is what I was referring to earlier in the Gusto trial way back in 1996, one of the early lytic trial, page 26,000 acute-MI patients, and only 145 of them developed a new left bundle branch blocks as a consequence of their heart attack, and confirmed by enzymes. So that's pretty unusual. You can have a heart attack though with left bundle, of course, and this would be an example where you see this dramatic ST elevation. This brings up the concept of concordance. And concordance basically just means if the STs are up in the direction of the R wave, then it only has to be up 1 millimeter to indicate a STEMI in a left bundle branch patient. Whereas if it's discordant, meaning the ST elevation on the opposite side of the QRS complex, then you need to have over 5 millimeters of ST elevation for it to matter. And that would apply here, you see. So the S waves are down, the ST elevation is very high on the other side. But even this little bit of 1 millimeter here in this lead, where it's concordant, could indicate ST elevation myocardial infarction. So this is just drawing that graphically. Left ventricular hypertrophy, so thick-walled ventricle, often results in alteration of the repolarization. So the way I think about that is if you look at these tall R waves, you see a left ventricular hypertrophy, and then you tend to see this downsloping ST depression opposite to the QRS complex, and that's expected with LVH. But if you look in the right precordial leads and just flip it around a little bit, here you have the S wave and you have the ST elevation right after the complex. It's usually V1, V2, sometimes V3. So that's often misinterpreted as an ST elevation myocardial infarction. And sometimes you just won't be able to tell without old EKGs, but if you see hypertrophy, hypertensive patient, maybe older, the ER physicians will often have to think about what to do there. Elevated potassium usually starts with these peaked sharp T waves, like you see here, and as it gets worse, it becomes a real kind of bizarre complex. The P waves disappear, even though they're there, you can't see them, and you get QRS widening. Usually, we think about the change with elevating potassium start from the T wave and work backward toward the P wave. So you see the first things happening out there, and then as it gets worse, it moves toward the P wave. And I think it's important to realize that who are the people that get hyperkalemic? There's only a few people that really do this, and as dialysis patients are the most common. So when you pick up a dialysis patient with a bizarre EKG, at least keep in your mind that maybe it's just potassium of 8 that's causing the problem. People who, if you get a drug list and you find they're on ACE inhibitors, potassium supplements, L-dactone or spironolactone, these are other medications that raise potassium and can cause severe problems. But kidney failure is the big one. Wolff-Parkinson-White syndrome, this is that kind of inherited disorder of conduction between the top and the bottom of the heart, can cause pseudo-infarct patterns. In the type A pattern, we see what looks like an infra-posterior infarct, so we have Q waves inferiorly to, actually 3 and F here, and the tall R waves in the right precordial can be posterior infarct. So this could be easily interpreted as an infra-posterior Q wave infarct. The other clue is the slurring upstroke of the QRS. So you see the slurring, you see a short PR interval and a slurred upstroke between the P wave and the QRS. That slurring is also diagnostic of Wolff-Parkinson-White syndrome. I won't dwell on this too long, but there is a fairly rare syndrome called Brugada syndrome you may run into. It's got this peculiar pattern in the right precordial leads where you see this RS, R prime, and then this like ski slope configuration to the T waves. It comes down to these inverted T waves. So it's a very specific kind of EKG, and before you can diagnose this Brugada syndrome, you have to have some other clinical factors. And the reason I mention this is because these people can have sudden death. So sudden death in a young person can come from this. It's important to realize that early on. Someone who passes out, they have an EKG like this. But it is a genetically transmitted type problem, autosomal dominant, so there may be family history of sudden death in these patients. These kind of things are needed to make the diagnosis, not made just on EKG alone, but when you combine some of these other family history and inducibility of VTAC, syncope, nocturnal agonal respiration, these various things add to that diagnosis. So I just think it's interesting, and one you might in your lifetime find a couple of these along the way, and you really look smart for the emergency room doctor. When you
We already did.
you already do, it's not a problem right now.
We already look smart in front of you.
So if I put this all together in this little mishmash here, you can kind of compare these things side by side. So you see the LVH, big voltage, altered repolarization right here. You see the left bundle with the wider QRS complex of this kind of fake out ST elevation here. Here you see acute pericarditis with diffuse ST changes, no reciprocal changes, PR depression, and then you see hyperkalemia, acute MI, obviously, and then the Brugada complex. You see how that looks up in the V1 lead, the right precordial lead right up here. So I'm going to show you some real cases. These are cases that came to us from the field and whatnot. So this is a 29-year-old male with chest pain, dyspnea, and weakness. Look at the. When I showed this to the PMG internists, I actually created a little quiz for them, and they had to check and make the diagnosis, and they could grade themselves afterwards. I won't make you suffer through that, but I'll point out that here you see this ST elevation, Q waves in 1 and L. So 1 and L, left-sided leads, lateral, think lateral infarct, also with the precordial leads out of the anterolateral. So this could be a left anterior descending artery, so I'm thinking of left anterior descending artery that wraps around, maybe includes a diagonal branch or comes around to the side of the heart. And so indeed what you see is this is the left anterior descending artery, should be here. So it's totally closed off. And actually I guess this is the thread of the LED right here. And after angioplasty, you can see that artery was restored. Some of these are a little hard to see. So this is an 85-year-old female, diffuse chest pain, diaphoresis. This is the field EKG. So you can see someone's already drawn circles around the ST elevation. So you see 2, 3, and F are right here. And this is a nice example of reciprocal changes. So 1 and L, kind of the opposite. Leads, you see the ST depression T-wave version. And here, sorry about that. I'm trying to keep my finger on. And you see there is also ST elevation out in the V1 or V3 lead out here in the precordial leads. So when she came in, that was the feeling. When she got to the hospital, this is what it looked like. So her chest pain had resolved, and this is the second total tracing, first EKG tracing. Now there's no signs of acute MI here at all. There's a little ST depression here.
There's no elevation in 2, 3.
So this is lead 2. There's really no ST elevation there. And the precordial leads here, like I said, if you use a 2mm cutoff, it's just not very specific. You know, it's a little hard to tell, but clearly better than this one. So you see that dramatic, so you know, we'll think, why is that? The aspirin and nitro you gave the patient, the drug. Turns out that actually this is a right coronary lesion, so when we got to the patient, there was still some flow through there. So it's not totally clipped off. You see 2 high-grade blockages in the right coronary artery, and when stented, all normalized. But there's some diffuse disease downstream. But anyway, sometimes this stuttering ST elevation up and down, it can be because there's intermittently some flow, depending on nitro drip, a little heparin, whatever. You get some flow going down through the STs, calm down. Patient still needs to be treated.
And if you think about that, if that lady had walked into the ED and that EKG would have happened on her way in with her husband in the car, they might not have diagnosed it.
Right,
You
no,
know.
exactly, it could have been the third EKG, when they started having pain again,
Right.
45 minutes later, was gonna show the ST elevation.
So this is a 58-year-old man with severe substernal chest pain radiating to his shoulders. So, some of these I haven't looked at in a while, so I'll review. This is kind of interesting because, so here's the limb leads, here's the precordial leads. You see on the precordial leads now, the T waves are flipped over and there's ST depression. There may be some ST elevation out here that's significant, but this is something to think about. And then you see leads 1 and L, so the lateral, high lateral leads I like to call them, have ST elevation at least 1 millimeter. So it certainly qualifies for injury right there. And you have a little ST depression inferiorly. So this one is one of those classic ones where if you take the EKG and you turn it upside down and look at it into the light, you can see that that's a posterior injury pattern. So the ST depression, the precordial leads, can actually be a posterior heart attack that's just reversed because it's in the back of the heart. So, those, and then you can see it, in fact it is, the circumflex is the vessel most notorious to cause this kind of problem. So you have an occluded circumflex marginal branch here that's opened up, stented. So this 40-year-old man with high cholesterol presents with 1 hour of chest pain. And so here again, we see ST elevation in ABL, which is a high lateral lead, maybe a trace here, maybe not diagnostic here. You see that depression, a reciprocal opposite kind of effect inferiorly. You also see some ST depression. This would qualify as an ST elevation MI here, the right precordial leads. Pointed that out here. So it turned out, this is a patient of mine actually, it turned out that when I got him in there, I saw this LED was totally occluded, and I didn't know if it was a fresh occlusion or an old occlusion, and this is a diagonal branch that's hanging on by a thread. So actually the LED here I probed was hard as a rock, couldn't get a wire through. It's chronic occlusion, infarcted segment, silent MI, never treated for it. And the reason it was coming in is because now the high lateral area, the diagonal branch, was causing the acute heart attack. So I opened this up with a balloon. This is a couple of 18 months ago or so, I guess. He came in recently, and he had a high-grade restenosis here, and he had other disease. I ended up getting him a quadruple bypass surgery. So in his 40s, he ended up with a bypass operation.
Can you go back to the 12 lead again?
Yeah, sure.
Is V4 not showing elevation?
Uh,
From here it looks
No,
like it.
there is a lot of elevation. I'm sorry.